Hello, everyone, and a very warm welcome to this IAPB and IDF online event, Diabetic Retinopathy, a call for global action. I'm Professor Serge Reznikov, and I'm the president of a French NGO, OPC, the Organisation for Prevention of Blindness, or the Organisation pour la Prévention de la Cécité in French. I'm also a conjoint professor at the University of New South Wales in Australia. Let me start with a few housekeeping points. First, this session will be recorded. You can also activate the Zoom-generated subtitles if you want to read them by clicking on the closed caption button at the bottom of the Zoom screen. But it's important to keep in mind that these subtitles are not 100% accurate because they're generated automatically. But the participants will receive a feedback questionnaire, and that you're all invited to fill. I think it's very important for us to have your feedback. In addition, participants who attended at least 80% of the live event will receive an attendance certificate, but only if they have completed the feedback questionnaire. So please check your spam folders, boxes, if you have not received it by April 15th, which is the day when they will be sent out. Last but not the least, please use the Q&A functions to share your questions with the speakers and panelists, and we have colleagues who are going to monitor this function so that we can discuss these questions at the appropriate time. It's my pleasure now to give the floor to the main sponsors of this event. The International Agency for Prevention of Blindness, IAPB, and the International Diabetes Federation, IDF. And we'll start with the welcome address from Peter Holland, the CEO of IAPB.
Hello, I'm Peter Holland. I'm Chief Executive of IAPB, the International Agency for the Prevention of Blindness, with the overarching alliance for the global eye care sector. I'm extremely sorry I can't be with you in person, but I'm delighted to welcome everybody to this really important occasion, the launch of the IAPB and International Diabetes Federation joint policy brief on diabetic retinopathy. I've been really excited about the collaboration between IAPB and IDF. Both alliances have been partnering for several years on raising awareness on screening, prevention, treatment, and the implications of diabetic retinopathy. We're IAPB, we're really pleased to host symposiums at the IDF Congress in 2017 in Abu Dhabi, and again in Lisbon at the IDF Congress in 2022. At Lisbon, we brought together eyes, kidneys, and feet, which catalyzed conversations around the so-called forgotten complications and demonstrated the convening power of both our organizations. We look forward to showcasing some of the work that will flow from this policy brief at the IDF Congress in Bangkok in 2025. Diabetes, of course, is now recognized as a global epidemic. The most common complication is diabetic retinopathy, which often leads to vision impairment and blindness unless it's treated and caught early. And that's where our collaboration really matters. We're advocating simultaneously for addressing diabetes and its common complications. This joint effort is especially critical, underscoring the need to ensure diabetic retinopathy screening is available and accessible for every individual living with diabetes. Because, of course, the impact of vision impairment goes well beyond the individual. Communities and societies lose earning capacity and productivity through the loss of human capital, experience, and expertise. And of course, sight loss due to diabetes is one of the most feared complications for people who are living with diabetes. But 95% of sight loss due to diabetic retinopathy can be prevented with early screening, detection, and timely treatment. Therefore, it's crucial that diabetes care includes eye examinations and that these are integrated into regular health screening packages. This policy brief, I hope, will be helpful for advocates, healthcare professionals, policymakers, and indeed people living with diabetes to make the case for eye health and diabetes care. The brief highlights the links between diabetes and diabetic retinopathy, underscores the impact and severity of diabetic retinopathy for people with diabetes, and demonstrates the need to develop an integrated and multisectoral approach to prevent and treat both conditions. I hope everybody on the call will have a chance to read the brief and then take action on its recommendations. Because of course we, indeed everyone, has a role to play in spreading awareness and driving positive change on the prevention of both diabetes and its complications, including diabetic retinopathy. I'd like to acknowledge and thank all of those who contributed to the development of the policy brief, the experts from IAPB and from IDF for their expertise and dedication. And I'd particularly like to thank Kova Bhaskaran, the chair of IAPB's Diabetic Retinopathy Working Group, who led the drafting of the policy brief. And of course, I'd like to thank all of you today for joining us, for your work and for your commitment. Together, our joint efforts can lead to real change by influencing policies and practices on diabetes and diabetic retinopathy around the world. Thank you.
Thank you, Peter. Thank you, Mr. Holland.
Thank you, Professor Resnikov, for your introduction. I'm afraid that work commitments here in Norway prevent me from joining you live today. On behalf of the network of 240 national diabetes associations in more than 160 countries and territories that comprises the International Diabetes Federation, I'm delighted to welcome all participants to this webinar. Diabetes and diabetic retinopathy are a growing concern that poses a significant challenge to health and sustainable social and economical developments. IDF estimates that over 500 million of people are currently living with diabetes. We have seen numbers triple in just 2 decades, which makes diabetes one of the fastest growing health emergencies of this century. If action is not taken urgently, we estimate that the number of people living with diabetes will exceed 700 million by 2045. This growing number of diabetes cases means that diabetes-related complications are also on the rise. This includes diabetic retinopathy, which is one of the more feared and common complications of diabetes, but does not receive enough attention. We are delighted to have had the opportunity to develop this important policy brief with our colleagues from the International Agency for Prevention of Blindness. This is important collaboration as it provides a series of recommendations that IDF and IAPB are hoping can improve the lives of people with diabetes retinopathy. I hope IDF and IAPB's network of advocates can make good use of this document for the national advocacy. I would also like to thank all experts who have contributed to creating the document, notably Dr. Bhaskaran, who has led the group. We also want to thank our colleagues from IAPB for their valuable collaboration. I will now pass the floor to my esteemed colleague, Dr. Bente Mikkelsen, Director of WHO's NCD Department, who will share WHO's work on diabetes and eye health. Thank you all for attending this webinar.
Thank you very much, Professor Hussain, for these remarks. And I would like now to invite Dr. Bente Mikkelsen, who is the Director of the NCD Department at the World Health Organization, to say a few words.
Dear colleagues and friends, as a director for the Department of NCD Rehabilitation and Disability at WHO, I would like to start by stressing that both the agendas of the eye care and diabetes are core to the NCD agenda. Both have long-standing history at WHO, with programs established in the 1970s and 1980s, respectively. These agendas are also personal for me. Since 2014, through various positions at global and regional level, I have had the pleasure of overseeing this important work of WHO. I would like to congratulate the International Diabetes Federation and the International Agency for the Prevention of Blindness for the launch of a joint policy brief on diabetes retinopathy. The documents provide clear recommendations to improve the prevention and care for people living with diabetes and diabetes retinopathy. The statistics outlined in the document provide a sobering reminder of how much work needs to be done in the field and how seriously both diabetes and eye care should be taken. One additional statistic I'd like to share comes from the recent WHO NCD country capacity survey that revealed that only just over half of countries reported that retinal photocoagulation, a primary intervention for treating diabetes retinopathy, was available in the publicly funded health system. Recognizing the need for determined intervention in these fields, WHO have taken a number of actions to drive these agendas forward in the recent years. One major milestone is the establishment of the WHO Global Diabetes Compact, created in 2021 on the 100 years anniversary of the discovery of insulin. The fact that 100 years after the discovery, the life-saving treatment remained and still are remaining out of reach for millions highlighted the need to move beyond business as usual. The WHO Global Diabetes Compact has the vision of reducing the risk of diabetes and ensuring that all people who are diagnosed with diabetes have an access to equitable, comprehensive, affordable, and quality treatment and care. To achieve this vision, the Compact has a focus on supporting member states to increase access to essential diabetes medicines and associated health technology, provide technical guidance on diabetes, improve health promotion and health literacy, support country implementation, strengthen research and innovation, and strengthen governance, strategy, and partnership. Within the NCD agenda, we are taking a cross-programmatic approach to address the key challenges to improve access to eye care services for people with diabetes. The fundamental priority over the coming decades needs to be the integration of people-centered eye care into national health systems in countries, and by making sure that the required services are available through primary health care. To support member states in this endeavor, WHO has recently published practical, step-by-step guidance and standards to strengthen the assessment, planning, and monitoring of eye care services, including those for diabetic retinopathy, across the continuum of care. It's a pleasure for me to know that you will hear more about this shortly from Dr. Stuart Gill. It is extremely encouraging to see the commitment of member states to both the diabetes and eye care agenda, with the WHO Health Assembly resolutions focused on integrated people-centered eye care and strengthening prevention and control of diabetes adopted 2020 and 2021 respectively, and new global targets for 2030 for both diabetes and eye care endorsed by member states in recent World Health Assemblies. What gets measured gets usually done. Concerted efforts towards these targets is fundamental in order to drive coverage for essential quality interventions for diabetes and eye care. However, of course, WHO cannot do this alone. Only through collaboration with partners like yourself and multi-stakeholders, including people with lived experience aligned around measures and targets, we will be able to tackle these challenges. Our common vision needs to be to ensure that all people who require diabetes and eye care services can receive them without risking financial hardship. So we look forward to working with all of you and to achieve the common vision. I wish you good luck with the rest of the meeting. Thank you very much.
Thank you very much, Dr. Mikkelsen, for these highlights of the work that WHO has been doing in the area of NCDs. I think it's been really great to see how WHO has increased the priority given to non-communicable disease. I think this is all very positive, and this is bringing us now to the next step in our webinar, which is setting the scene and particularly presenting the policy brief. And it's my pleasure to introduce Dr. Covadonga Bhaskaran, who has been leading and coordinating the working group that has produced this policy brief. Kova, the floor is yours.
Thank you, Serge. I am very pleased to give a brief overview of the policy brief today. Next slide, please. You can download the brief through this QR code on the slide. And it will also be available on the IDF and IAPB websites in due course. So next, please. The objective of this document is to provide policy recommendations to effectively prevent and manage diabetic retinopathy in order to avoid visual loss in people with diabetes. We're directing this to advocates, healthcare professionals, and policymakers working in diabetes and eye health. Diabetes is a global public health problem, and we've already heard the numbers. Currently, there's an estimated 537 million adults that are living with the condition, and this is predicted to reach 1.3 billion in 50 years. This trend is largely determined by the increase of type 2 diabetes, which is rising rapidly in low and middle income countries, where already 75% of people with diabetes are living. As you can appreciate from the map, in many countries in the world now, which I have marked here with a yellow dot, more than 1 in 10 adults has diabetes. Next, please. The global prevalence of diabetic retinopathy is increasing in parallel to the increase in diabetes. So there are over 100 million people with diabetic retinopathy globally, and that's approximately 1 in 5 adults with diabetes has diabetic retinopathy, around 22% prevalence. 1 in 10 adults with diabetes will already have a severe stage of diabetic retinopathy that requires prompt treatment to avoid visual loss. Africa, as you see, is the region with the highest prevalence of diabetic retinopathy, and the Western Pacific region has the largest numbers of people with diabetic retinopathy. There is a real urgency to address diabetic retinopathy globally, and particularly in low and middle income settings, where the magnitude of diabetes and its complications is disproportionately increasing. Next, please. Now, all people with diabetes are at risk of developing diabetic retinopathy, which is the most common macrovascular complication of diabetes. Diabetic retinopathy is also the 5th most common cause of blindness, and it is particularly concerning that while the other 4 leading causes of blindness have decreased in the last decade, diabetic retinopathy continues to increase. Vision loss is one of the most feared complications for people with diabetes. We know vision impairment reduces mobility, reduces work productivity, and it is associated with increased mortality and poor mental health. Vision loss due to diabetic retinopathy can affect the way a person manages their diabetes, leading to development of other complications and to enter a vicious cycle of emotional strain. Globally, diabetes care accounts for 12% of health expenditure, but there are marked differences between low and high income regions. The regions that have a large number of people with diabetes are also those with less expenditure and more health system challenges to deliver good diabetes care. Additionally, visual impairment is associated with a large annual economic productivity loss, and diabetic retinopathy is in many countries the leading cause of blindness in the working age population. The cost of healthcare is higher for people with diabetes than for people without it, and it is even higher for those with diabetes that develop diabetic retinopathy. To reduce the impact of diabetic retinopathy on the healthcare budgets, it is crucial to implement strategies to prevent the development of diabetic retinopathy in people with diabetes and to prevent the progression of diabetic retinopathy to visual impairment. Next, please. The first step is to prevent the development of diabetes, promoting physical fitness and weight control, general measures in the general population. For people that already have diabetes, maintaining a good glycemic and blood pressure control can prevent the development and progression of diabetic retinopathy. Additionally, we need good management of diabetic retinopathy, and there are two steps. First, to detect the condition early enough through screening, and second, to treat the condition with laser, intravitreal injections, or vitreoretinal surgery. Next, please. So diabetic retinopathy-related visual impairment and blindness can be largely prevented through early detection and subsequent timely treatment. And a multisectoral response is crucial for this. Both primary and secondary prevention measures for diabetic retinopathy need to be delivered as part of diabetes care. This includes measures to prevent the development and progression of diabetic retinopathy, like glycemic and hypertension control, but also measures for early identification of diabetic retinopathy before it has given visual symptoms, such as retinal screening. The tertiary prevention is the treatment that is delivered by eye specialists as part of eye care services. It is obvious that a strong collaboration between diabetes and eye care services is essential to help people with diabetes navigate the clinical pathway effectively. Next, please. So this brief presents 8 policy recommendations. The first one is to integrate diabetic retinopathy in all diabetes policies and national health strategy plans. Next, please. The second recommendation is to respond to the increase in number of people with diabetic retinopathy at risk of visual loss by improving access to diabetes care at all levels, including diabetic retinopathy. Next, please. Number 3 is to implement diabetic retinopathy screening and treatment interventions that are contextually appropriate to the setting. Next, please. The fourth recommendation is to provide universal coverage for interventions that reduce the risk of visual loss in people with diabetes. This includes the screening, equipment, and the drugs to achieve this. Next. The fifth recommendation is to advocate for people-centered diabetes and eye care and engage people with diabetes in the development of policies that address their needs. The sixth is to promote and fund a research agenda for diabetes and diabetic retinopathy that includes health systems research and research into the technological innovations that can impact practice. The seventh recommendation is to include diabetic retinopathy in the global diabetes targets and promote and fund the collection of population-level data on diabetic retinopathy and visual impairment that are needed to measure these targets. And finally, the eighth recommendation is to strengthen the national capacity to collect, analyze, and use data from health services on diabetes and diabetic retinopathy, so we know about the magnitude and the trends of the conditions in order to monitor and evaluate the progress. And this is a brief summary. I encourage everyone to download the full policy brief, and thank you very much.
Thank you, Kova, for this excellent presentation on the policy brief and the main policy recommendations. And thank you again for the wonderful job that you have done with your group of IDF and IAPB experts to distill these policy recommendations. It's my pleasure now to introduce Dr. Stuart Keel, who is leading the work on vision and eye health at the WHO headquarters in Geneva in Switzerland. Stuart, the floor is yours to present on the work on diabetic retinopathy.
Thank you so much, Serge. Thank you. So yes, over the course of the next 10 minutes or so, I just wanted to provide a brief overview of WHO's work on eye health and diabetic retinopathy. If we could go to the first slide, please. So WHO's work, very briefly, is guided by a resolution that Bente alluded to earlier on eye care that was endorsed by member states in 2020. And this was titled Integrated People-Centered Eye Care, including preventable vision impairment and blindness. So I'm not going to go through this resolution, but really the take-home message, if we could click through, is for member states or countries to implement integrated people-centered eye care in their settings and in their countries. So next slide, please. So what is integrated people-centered eye care? So as described in WHO's World Report on Vision from 2019, integrated people-centered eye care promotes that the planning of eye care services should be done so in line with the 4 key strategies that are outlined on the slides, and that is engaging and empowering people and communities, reorienting the model of care based on a strong primary care and also community care, coordinating services within and across sectors, which of course is very relevant to the event and the discussion today, and creating an enabling environment for the integration of eye care in national health plans within countries. Next slide, please. So to support countries with the implementation of integrated people-centered eye care, WHO has developed a number of technical resources, as Bente alluded to previously, and we've received input from well over 300 experts in developing these tools. So very simply, these tools are designed to support countries through a phased process that starts with the situation analysis of the eye care in a country. Phase 2 is then the development of an eye care strategic plan and monitoring framework. Stage 3 is the development of an operational plan and to support its implementation. And then there is finally a periodic review phase. And given that diabetes is a very important cause of vision impairment globally, as we've heard today, it features very strongly within all of these broader eye care related documents. Next slide, please. So going into these documents in slightly more detail now with a focus on the diabetes and diabetic retinopathy components. So if we were to look at the situation analysis tools, WHO has 2 separate tools that are available depending on the country focus. There's a broader tool to analyze the situation in a country called the Eye Care Situation Analysis Tool, or the ECSAT. And then there's the TADS tool, which is a specific tool to assess both the management of diabetes and diabetic retinopathies and diabetic retinopathy in countries, and to estimate the sort of synergy between the 2 sectors. And these tools are really designed to answer 3 key questions, and that is, what is the current situation of eye care and diabetic retinopathy in the country? What are the priority areas that need to be addressed in strategic planning? And what are the possible activities to address these gaps? Next slide, please. So this slide presents the key priorities based on the analysis of the situation assessment for diabetic retinopathy that has been implemented in over 83 countries so far. And I think these key priorities won't be a surprise to many of you. And the first one is the need for diabetic retinopathy clinical management guidelines that the Ministry of Health endorsed and aligned with diabetes guidelines. The second priority is improved integration of diabetic retinopathy screening in diabetes service delivery. The third is improved affordability and access to diabetic retinopathy treatment, technology and medicines. And then we have integration of indicators for diabetic retinopathy within general health information systems and strengthening health promotion and prevention. So over the course of the next couple of slides, I want to highlight a few examples of how WHO is trying to support countries to work on and address these priorities. Next slide, please. So we saw one of the priorities was to integrate indicators for diabetic retinopathy into national health information systems, and to support this, WHO has a broader eye care indicator menu that's been developed that contains a comprehensive range of indicators ranging from input indicators all the way through to impact indicators to facilitate monitoring of strategies and actions for eye care in general. Then there's some more specific guidance and also a DHIS2 module that's been developed that include a core set of facility level indicators for both eye care and ear care. And this tool can be adopted quite simply in countries that use this DHIS2 software within their health information systems, but can also be adapted in countries that also don't use this software. Next slide, please. So within these tools, there are relevant indicators related to diabetic retinopathy. And one is the financial risk protection for diabetic retinopathy laser treatment. Then there's also a very important indicator related to retinal screening coverage for people with diabetes. So this indicator is also incorporated within the DHIS2 module, and we're working with our academic partners at the moment to try to formulate a baseline for this particular indicator, really recognising it is a very important indicator to really raise the profile of diabetes and diabetic retinopathy at the global and the regional level. Next slide. So for the remainder of the presentation, I wanted to mention another key tool at WHO, which is a package of eye care interventions. And this tool provides recommendations on evidence-based interventions, including all of the resources required for their implementation across the continuum of care from health promotion through to vision rehabilitation and across all levels of the health system. So it really provides a blueprint for eye care in countries in order to achieve universal health coverage in eye care. So the purpose of this tool is really to facilitate countries' decisions on which interventions to prioritise, and then how can they be integrated in health services packages and policies. Next slide, please. So I wanted to now just look at the key interventions that are included in the package that are related to diabetic retinopathy. And there are 8 in total. There's one health promotion and prevention that's very much in line with the COVA's mentioned recommendations from the policy brief, which is the control of key risk factors for diabetes. I wanted to mention one of the WHO tools to help support the implementation of this recommendation, which is the Be Healthy, Be Mobile Diabetes tool, which is a systematic message-based program to improve population awareness and prevention. There's also the key screening intervention, of course, routine screening for people with diabetes for diabetic retinopathy. And again, WHO has some relevant guidance that's been developed by our regional offices in the European region, but also the Southeast Asia region. There's those 3 key treatment interventions that are in line with what COVA mentioned before: anti-VEGF therapy, retinal laser photocoagulation, and vitreoretinal surgery, and a range of vision rehabilitation interventions for people with irreversible vision impairment and blindness. So if we look specifically at one of these interventions now, just to give an idea and a flavour of the type of information that's included in the package. Next slide, please. So for each of these interventions, the package includes details of the relevant period of the life course in which the intervention should be available to, the levels of service delivery that it should also be available within the health system, the links to health programs, including, in this case, of course, non-communicable disease and diabetes care, and the equipment, medicines, and consumables required for the implementation of the intervention. So I wanted to mention an important outcome is that all of the devices for the interventions that I showed on the previous slide have now been included within WHO's priority medical devices list, and they're all in the process of being included within WHO's broader universal health coverage intervention packages and costing tools, with really the aim to support countries in planning for the inclusion of these priority eye care interventions within their health services packages. Next slide. Thank you very much. Please don't hesitate to get in contact with the team for any questions. And again, congratulations to the IDF and IAPB team on the launch of this important policy brief. Thank you.
Thank you. Thank you, Stuart, for this very comprehensive presentation of the impressive work that WHO has been doing in the area of diabetic retinopathy prevention and management. And thank you for presenting the wide range of tools that are existing and that have to be implemented at the country level. And this leads us to the next presentation. And it's my pleasure to introduce Dr. Fernando Melerbi from Brazil, São Paulo, the Unifesp University, who will discuss with us diabetic retinopathy landscape in Brazil. Fernando.
Thank you very much. Thank you very much for the kind presentation and for the opportunity. So I'll be talking about some actions that we've been performing in Brazil, along with the Brazilian Diabetes Society also. Next slide, please. So Brazil is in the ranking of the countries with numbers of patients with diabetes. We are at number 6. So we're a very huge country, continental proportions. We have large amounts of patients with diabetes who need control of the disease itself and also their complications. We have some numbers regarding Brazilian reality, regarding dialysis and kidney failure. Diabetes is among the top causes for patients to go to dialysis, and also for blindness and retinal diseases. We don't have still that number, but we see a lot of people with end-stage diabetic retinal disease, retinal detachment, vitreous hemorrhage, neovascular glaucoma. And we're trying within the academia and in talks with the government to change this reality. And next slide, please. So we performed the research within the Brazilian public health system, the SUS, which is a universal, free of cost to the end user system, regarding the coverage for DDR screening. And the numbers are not very good. So we can see that it's averaging 20% of the demand. Would like to emphasize that 3/4 of the Brazilian population rely exclusively on the public health system. So this is the reality of DR coverage in 2019. And when we see epidemiological studies, the global studies, it seems that in our region we have a lower prevalence of diabetic retinopathy, but actually we don't have good quality studies for epidemiology on this disease in our area. Next slide, please. This is the reason why we started at the Brazilian Diabetes Society a multi-center study to evaluate the prevalence of diabetic retinopathy in Brazil. So this is an ongoing study. We have already concluded the pilot phase of the study in Porto Alegre, southern Brazil. I'd like to congratulate the fantastic research team who helped gathering quality data. We are now studying these populations in northeastern Brazil, in Aracaju, and also in southeastern Brazil, in Minas Gerais. This is ongoing right now, and we hope that at the end of the study, we have a reliable number in order to help authorities to design public policies. Next slide, please. Along with the multi-center study, we also would like to highlight some examples of pilot and regional initiatives that have been occurring in Brazil in the last years. So we have been involved in pilot studies for the screening of remote populations. We have the example of the Chavante Indians. They live in central western Brazil. They're very, very isolated. They have increasingly high prevalences of diabetes and its complications. And we could make a proof of concept of screening these individuals with portable devices. We also trained teams from the family health strategy, nurses, to obtain photographs of the retina that could be examined remotely by retinal specialists. And these teams, they delivered high quality images, which provided a very robust screening system. Next slide, please. Some other examples, we have some initiatives with telemedicine around São Paulo metropolitan city, also in the states of Goiás, which is central Brazil, and in Rio Grande do Sul, southern Brazil. We have some initiatives in the November Awareness Month with mass screenings around the country. They are all following the example of Itabuna, which is in Bahia, which has a very robust screening program. And we have also looked at it in the hinterlands of northeastern Brazil. And we could publish a paper in the WHO bulletin saying that we have to tailor global strategies to local realities. Next slide, please. So this is my last slide. The Brazilian Diabetes Society has been the main voice on diabetes advocacy in the Brazilian parliament. So we have several initiatives. We have been talking to the regulatory agency of health regarding the implementation of AI, for example. We also have some special sessions in the Senate, as you can see in the photograph, when the directory of the Brazilian Society, in order to raise the awareness on the problem. I believe this is my last slide. I'm looking forward to the Q&A panel. Thank you very much.
Thank you very much, Fernando, for sharing your experience and expertise in the work that's been done in Brazil. And I think, again, it shows the very wide range of initiatives that can be implemented, and it's really very informative. And I would like now to invite Professor Şenaz Karadeniz, who is an ophthalmologist and a board member of the Turkish Diabetes Federation. Şenaz, the floor is yours.
So, thank you, Serge, and dear all. Could we please have the next slide? Can we have the next slide, please? Since several decades, we have, Since several decades, the previous slide, please, with the declarations, and the previous slide, please. Can we have the previous slide, please? Since several decades, we have a good evidence base about what diabetic retinopathy is, the importance of screening, treatment of sight-threatening disease, and good metabolic control, besides further research on diabetes and its complications. We have also many declarations, resolutions coming of international and supranational organizations showing the political commitment for reducing the burden of diabetes on the ground. Since at least 1989, started with the St. Vincent Declaration in Europe. These also point to the need for multi-stakeholder approach, including civil society. But as the skyrocketing numbers of diabetes and its burden shows, the implementation of these political commitments are unfortunately not the case. Next slide, please. We all need to review the challenges. May I have the next slide, please? We all need to review the challenges in implementing these commitments. I strongly believe that there is a need for making more room for the NGOs at all levels. As NGOs, we can largely contribute to the development of the policies. Therefore, we should be actively involved from the initial phase and design the policies with solution-oriented, constructive discussions together with all stakeholders, including the governmental institutions. Again, the NGOs can largely contribute to raising awareness and mobilize the community for their cause. We can also largely help the implementation of these policies and their monitoring. Last but not least, NGOs in the field of diabetes, we have long-term commitment to the cause than any other organization or stakeholder. We have just listened to the Diabetic Retinopathy Initiative of the Brazilian Diabetes Society, together with other stakeholders in the country. I'm pleased to give another good example from Turkey about how NGOs can contribute to the development of national diabetes plan, and also how they can do the close monitoring. The two initiatives coordinated by the Turkish Diabetes Foundation in collaboration with other NGOs, governmental institutions, and other stakeholders. The Diabetes 2020 Vision and Targets projects and the Diabetes Parliament. Because of the time constraint, I can talk about these if there are any questions during the Q&A session. Next slide, please. Back in 2015, all the United Nations members agreed on 17 Sustainable Development Goals to be achieved till 2030, with the aim of peace and prosperity for people and the planet. Good health and well-being are among them. The 2023 report does not look promising for the future. Therefore, they recommend as a rescue plan 3 major breakthroughs. One of them is equipping governance and institutions for sustainable and inclusive transformation, with an emphasis on partnerships and strengthening of engagement with civil society, among others. So a further goodwill is set forth in many of the political commitments so far. So next slide, please. Recently, NGOs were key partners in the assessment, design, and implementation of responses to the coronavirus pandemic. But reducing the burden of diabetes needs a long-term investment with long-term goals and short and mid-term achievements. So not to be overcome in a few years as in an acute disease. As we witnessed so far in real world, it would sound too romantic to expect such a long-term commitment from the governments or other institutions, except the NGOs in the field. Plus, the relationship between the governments and the NGOs may be somehow complex, multifaceted, especially in some of the developing countries. But beyond the scope of my today's presentation, the last slide, please. I strongly believe that we have now a strong call and huge opportunity to make this call be heard by all through 2 worldwide organizations and with the national members. Thank you.
Thank you very much, Ines, for highlighting the absolutely critical importance of NGOs and non-state actors and civil societies. I mean, all these component of the society that may really make a big change. There is another very important perspective also. It is the perspective of people living with diabetic retinopathy. And it's my pleasure now to introduce Mrs. Chimizi, who will tell us about her personal experience. And she's from Nigeria, and she's one of the members of the IDF Blue Circle Voices. Chimizi, the floor is yours.
Thank you so much. My name is Chimeze. I am from Nigeria, and I have been living with diabetes for the past 11 years. Being diagnosed a day before my 26th birthday was a life-altering moment for me. It has never been an easy journey with diabetes, especially in Nigeria. Marking my birthday, and welcoming diabetes as well in my life was something I never wished to experience. But every day we move on. There are many things, living with diabetes has taught me. And after I was diagnosed with diabetes, prior to that diagnosis, I've already developed many complications. I was experiencing blurred vision, frequent urination, dehydration. The one that I got to know later that it was a neuropathy. I stayed in the hospital for quite a number of days, and this was actually during my early days in the university. And when I was discharged, my vision has already deteriorated, and then I started using my mother's medicated eyeglasses so that I was going to be able to read and see things. Having experienced that blurred vision and being a novice in things about diabetes, I was constantly visiting the hospital. And one of those visitations in the hospital, I complained to the doctor about my experiences, which he concluded that I was experiencing retinopathy, and some medications, eye drops, and the journey started. It has been a very hectic journey, something that I would never wish to experience, especially living with diabetes in Nigeria. I experienced a lot of stigmatization from people, and that's made me to keep my struggle with diabetes private. I don't share my experiences with people because I was constantly judged. I was constantly stigmatized. Diabetes and its complication, it took a toll on my personal relationship. It took a toll on my love life. It got to a time in my life as a person living with diabetes, I got engaged with something that I will tag as the love of my life, but along the line, the parents of the guy decided that because I was living with diabetes, that the young man should not go ahead with the marriage. And then I lost that love, and it was really hard. As a person living with diabetes in Nigeria, it's like I said earlier, it is quite difficult. It is a worrisome situation to live with diabetes in Nigeria because the government of my country, they don't really prioritize the health of people living with diabetes in Nigeria. It is quite difficult for you to access diabetes supplies. And then one of the challenges we face in Nigeria is a limited number of doctors specialized in diabetes management. In Nigeria, from my own perspective, I will say that single ladies, young women living with diabetes face heightened stigmatization compared to the male folks. I go through these challenges every now and then, and being that I constantly face this stigmatization, I don't share this information. Up to now, after 10 to 11 years of living with diabetes, I still live in denial. I still cannot openly discuss about my health challenges because of the judgments I will receive from people who do not know the daily struggle I go through as an individual living with diabetes. But however, I've experienced love, I've experienced encouragement from my families and few individuals who has been on this journey with me, who knew about diabetes before me. And then, many of them will tell you that you can live as long as you want with it. So it's quite encouraging somehow, to see that or to live every day knowing that some person's got your back. But in spite of all these things, I choose to live. I choose to be joyful, do as much as I can to improve my management and accept the support I get from family and friends, and also, be able to digest the stigma, the discouragement I get from people who do not know anything about the daily struggle. I also believe that as a nation, Nigeria, they can do better to prioritize the health of their citizens, especially those living with diabetes and its complication. Here in Nigeria, we hardly have access to the necessary medical medical equipments to have your diagnosis. Even up to now in Nigeria, you can hardly have access to a medical equipment that would differentiate between type 1 diabetes and type 2 diabetes. The diagnosis of retinopathy and neuropathy and all these complications, we hardly have those facilities in Nigeria. And then I know that we can grow, we can do better as a nation. And as an association of, we have Diabetes Association in Nigeria, I know that they can still do better to prioritize the life and the challenges of people living with diabetes. Living with diabetes has never been an easy journey, especially for young people in Nigeria. You constantly struggle to have access to those supplies. The inflation has really caused people living with diabetes a lot of more challenges, because ordinarily an insulin that was a bit affordable for people living with diabetes has really been a difficult thing for people, for us to get. I know that WHO, they are doing much, and the IDF are also doing their best. But I really want my country, the Nigerian government, to prioritize the health of people living with diabetes. I would like to stop here and then attend to any question from the audience. Thank you.
Thank you very much, Chimsi, for stressing the importance of the stigma and the importance of the social, economic, and cultural environment, and depending on the country where people are living. And it's time now to have some questions and discussion with the panel. The questions are coming through the Q&A session. I'll ask everyone to kind of keep the answers as brief as possible, so that everyone has a chance to participate. And the first question that I have on my list is for Chimsi. How did you feel upon receiving your DR diagnosis? I mean, is there anything that could be improved when announcing that to the patients?
The very first day I got the information that I was going to live with diabetes for a very long time. It was the worst day I never want to wake up to. It was quite disheartening, being a novice, yeah, I've heard about diabetes prior to that date. And then that diagnosis coming a day to my birthday took a toll on my life. And it was a turning point. Yeah, it wasn't really an easy one. Sorry, can I get the second question?
No, it was, is there any recommendation how to better announce things to the patients?
I think there is no other way you can do it apart from, telling the patient that this is what it is. And then bringing yourself to the level of that patient. Yeah, the time I was diagnosed, it wasn't really a good experience because the doctor I was admitted at her hospital was not friendly. And I think the best approach to it is for medical practitioners to bring themselves to the level of the patients. Words of encouragement can go a long way. There are so many best approaches to tell the patient that this is exactly what diabetes is all about, and then encourage the person. You can go as far as getting a group where the person can, get connected to people living with diabetes and know that, yeah, you are not alone. There are other people living with this. And then rather than leaving the patient to his or herself to work things out, to figure things out, So I actually got encouraged after I was diagnosed. I started making research, and that was how I got to know that there was something like Diabetes Association of Nigeria. I got connected to some of them, and then many of them, I became close to some of them, and some told me that a particular woman, Lion Chima, told me that she has lived with diabetes for a quite number of years. She was able to give birth, and it was encouraging for me to, to start that process, so yeah.
Yeah, thank you. Thank you, very helpful.
Thank
you. The next question is to Dr. Fernando. One participant is wondering if the data that you have presented are specific to Brazil, can be extrapolated to what is happening worldwide.
Yeah, thank you for the question. So Brazil is a very big country, continental dimensions, large population, and a large number of patients living with diabetes. So we believe that every country which has those characteristics, and there are lots of them in the world, could benefit from such approach with telemedicine, remote evaluation, mobile devices, maybe AI also. So the data are related to Brazil, but we are encouraged to see them being collected worldwide.
Thank you. And I mean, by the way, among the other member of the panel, is there anyone who kind of comment about how DR may be impacting countries differently? Any kind of other kind of experience that about the range of the situation that may happen, depending on whether you're working in a very low income country or a high income country, or you feel that it's all the same everywhere? Maybe Stuart, if I can put you on the spot.
Yes, I think also referring to, there are some great guidelines that are available in the eye care sector for the management of diabetic retinopathy, ranging from the screening intervals and so on, through to the use of technology. And I think one example is the International Council of Ophthalmology guidelines on diabetic retinopathy that do have this staggered approach for lower and middle resource settings and higher resource settings as well. So I think they provide a very good blueprint for how a country may plan out their services and screening intervals.
Thank you. Anything to add from Senaz, for example, from the kind of more the diabetology side?
So, thank you. Actually, I think one of the most important thing is when we speak about screening and so is the close either to have them in one point or have good reference systems or good collaboration with primary care, with the internist and the endocrinologist, so that the patients are referred to. Because the problem is people do not go to the eye check unless they have some problems, visual complaints. So therefore, we have to find the people with diabetes before they have any complaints, as emphasized before as well. I think this is also one of the things we have to emphasize. Thank you.
Yeah, thank you. Yeah. So, what I understand is that there are a lot of commonalities actually across the different countries. And one of the key issues is the integration of eye health with diabetes care, and that the one-stop approach is something that may be helpful in all places. So, but the next question is more about like the person level. What are some of the most effective preventive measures that individuals can adopt to mitigate the risk of diabetic retinopathy? So this is more like at the individual level. And the question is open to the panel. I mean, Kova maybe, or Fernando.
Yes, thank you, Serge. I mean, to prevent developing DR, the main effective measures are to control the glycemia and hypertension. Those are the two key areas. And they both also help in delaying progression of DR for people that already have got diabetic retinopathy. So they're the two clear measures, I think.
Okay, thank you.
So, I totally agree. But I would also like to emphasize the importance of education. Like it was said before, due to the asymptomatic characteristic of the disease. So people, they have to be told that they maybe have something that may progress to a vision-threatening disease, and they should be, even if they have no symptoms.
Thank you. And actually, I mean, we have another kind of several questions that are coming around the same kind of issue, and which is, can diabetic retinopathy occur even if diabetes is well controlled? Sheraz?
Yes, it can. Unfortunately, yes, it can. But as emphasized before, the important thing is not the presence of diabetic retinopathy, but the important thing is that the person with diabetic retinopathy doesn't have any visual complaints. So therefore, if they have timely screening and if they have timely intervention when needed, if the cyclotenic retinopathy is there, so this is the most important thing. But unfortunately, today we are not in a position to prevent the diabetic retinopathy from occurring. I mean, thank you.
Well, I mean, which basically means that kind of regular screening is necessary even in patients that have a diabetes that is well controlled. So there is no kind of exception to the screening process. Are there kind of diet-related interventions that could help with DR management? That's another question that came. Anyone wants to answer that one? Is there anything that magical that you could eat or not eat to make that there is no diabetic retinopathy?
Serge, I mean, Shanaz, you might be a better person to answer this.
Yeah, yes, please.
I'm not aware that there are. However, keeping fit and not overweight, because obesity is a compounding factor. So, you're more likely to progress in diet, particularly if you already have diabetic retinopathy, you're more likely to progress if you are also obese.
Yeah.
So in that sense, there is a nutritional connection, but I'm not aware of any magic superfood for it.
Unfortunately. Anyone to add on to that? Or it's kind of, this is what Kova said. Any additional thoughts? If not, I think it's quite clear that, well, there is nothing magical about it. The next question that we have is about the NGOs. We have seen through Shanna's presentation how these NGOs may play an important role. But what kind of challenges NGOs may be facing? Fernando, Shanaz, you're kind of speaking on behalf of the countries, or Shimsi, any thoughts about that?
I believe they perform a wonderful job, but sometimes there are only local initiatives due to lack of funding. So if we have public policies to guide them all, I think that would be really, really great.
I mean, I think the word policies is a very important one. So how do you see that NGOs can play a more important role in terms of kind of policy setting, or policy orientation, or policy information? Is there anything that we, as a global community, and here we're like people representing IAPB on the one hand, IDF on the other hand, is there anything that we could do better so that we are playing that role? Any recommendations?
I'll give just a quick example. In
Sure.
Brazil, we have NGOs that propose mass screening events for DR, so they can perform exams of 500 persons in one morning and laser them afterwards. But once the event is over, then this patient will be back to the public system, and probably he or she will not have a sequence on that. So this is what I mean.
So it's very much about integration of the work that the NGOs are doing within the national health system. Any additional thought? We have many other questions. So yeah, Shanaz.
I think one of the things is to make, as Fernando expressed, I mean, to make it not only one event. And so we have to bring the NGOs together in the field and act together so that we have a stronger voice. And this is also important in bringing diabetes and related issues to the attention of the policymakers in the country, to make diabetes one of the priorities and the health agenda. So this is what we have done also in Turkey. This is the NGOs of patients, healthcare professionals, nurses, and so, I mean, we brought them all together as the Turkish Diabetes Foundation and done all our, most of our organizations together with them. And I think that's why we have brought a lot of positive change in Turkey regarding diabetes. Thank you.
Thank you. Thank you very much. I think we have also a number of questions where we have technology that is like the main point, and technology has been kind of mentioned, addressed, discussed in several presentations, in most of the presentations actually. So maybe the first question to Kova: what are the kind of current opportunities in technology innovation in DR programs, and will these actually impact DR's outcomes?
Thanks, Serge. I think there are probably two key innovations that are enabling more effective diabetic retinopathy management. And the first one, which is not new, is digital photography. And this allows to take an image of the retina. So visualizing, looking at the retina was previously a task that only eye specialists could do through ophthalmoscopy. However, by having a digital image, you can now have non-ophthalmologists or non-eye specialists having a clear view of the retina. So in most high-income settings, this is already the mainstay to visualize the retina in the context of diabetes. And in many low and middle-income countries, retinal cameras are already present as well. They're taking over. So I'd say that that's one key innovation. As I say, not new, but that it's probably new that is spreading to this level in low and middle-income settings. And the second one, which is linked to it in part, is artificial intelligence, which Fernando's already mentioned. And this is important because not only you don't need a specialist to visualize the retina by taking an image, but you also don't need a specialist to grade the level of disease in the retina, at least to a level of is there disease or is there no disease. So if we think what we mentioned before, Shanaz already said, patients coming with visual symptoms to the eye clinic are not a solution to the problem. We need to see patients early on. To see them early on, you need to see them where people with diabetes are routinely going for their appointments for other reasons that are not to do with visual loss. So having cameras and automated grading could potentially increase massively the coverage of screening. So I think, cameras are very much an innovation that is there now. AI is still an innovation that is in development, although it's applied already in programs around the world, and in other programs it's been validated. But I think those are the two things that could completely shift and integrate DR screening and treatment. Yeah.
Thank you, Kova. And let's kind of continue kind of diving into this question about technology and telemedicine. And Fernando, you mentioned telemedicine in rural areas in Brazil. But I mean, what happens when someone is diagnosed with DR in a very remote area, in a place where actually there is no resources to provide the appropriate care?
So, excellent question. When we are calling to help designing such programs, this is the first question that arises. What should be done with the individuals who are screened positive, right? So it is fundamental that beforehand we have this very clear what would be the path for treatment. And we have mobile units. We can take laser machines to some places. We can take patients to other centers depending on the regions. But it is essential that when we design a program, we think of that ahead before starting. Otherwise, we will do some harm to the patient, just letting them know they have something that is threatening their vision and not doing nothing about it.
So basically, kind of what I take from there is that the system in which you're implementing anything is very important. So it's not just about the technology itself is a tool, but it has to be part of a system, including a referral system.
Absolutely, yeah.
So kind of following again on this this discussion about places where their resources are limited and sometimes extremely limited or non-existent. My question here is now for WHO, which is supposed to sort everything, of course. And so what WHO could do to kind of to support ophthalmologists from countries where the resources are really very scarce to take care of all these cases. I mean, in other words, I mean, how the different tools that you have presented can be actually made available and implementable by the people in the low income or in the low resource settings.
Yeah, thanks a lot, Serge. So yeah, because it's quite obvious that routine screening and access to treatment is very successful in reducing diabetes-related blindness. We've seen that in several high-resource settings such as the UK, Singapore, Sweden, many other settings. However, the challenge, as you rightly put, is many of the human resource availability, but also the technology availability is not at that level in the lower resource settings. And even, you know, if we think about the equipment of a retinal camera, if we want to buy a retinal camera for a primary care clinic in a low resource setting, it would be by far the most expensive piece of equipment in that particular clinic. So we're really coming at it from that angle, and there's a need, and I think there's been great progress in this space to develop these lower cost imaging systems. I think also, if we think about then the diagnosis, you know, if there's only a handful of ophthalmologists in a given country, we can't put extra burden on them to grade all of these images. So AI can potentially play a key role. But one of the challenges we face is that, of course, AI in diabetic retinopathy is at a very advanced, sophisticated spot. However, there's so many systems that are available. How does a country select what's most suitable to them? So setting standards and support in that front is also very important. And then really, you know, advocating with the WHO tools that, of course, now include, you know, all of these key devices for the core diabetes and diabetic retinopathy related interventions to include these core interventions and devices as part of their you know, their health benefit packages in and available in the public sector is, of course, very, very important. So I think the guidance is there from WHO that provides good advocacy support for that, including these devices being on the priority medical devices list at WHO. But of course, there is still work from here to then implement. They're just a few thoughts there, Serge.
Well, thank you very much, Stuart. I mean, yeah, this is obviously a very, very complicated question, and if we had an answer, I think we will not be here having this webinar. We have only like 5 minutes left before the end of the session. So I've kind of I will restrict the question now. Maybe there is the intersectoral collaboration and integration of services are key to prevent diabetic retinopathy. What do you think are the main barrier for these? And I'm asking the question to Kova very, very briefly, please.
Thanks, Serge. I mean, there are several issues, but I'll try to be brief. So one, I think, is that historically, because only ophthalmologists could visualize the retina, screening stayed in the ophthalmology departments. And therefore, there isn't that historical ownership in the diabetes department of looking at retinas and thinking about diabetic retinopathy in the same way that probably other complications are addressed. So I think there's a historical issue there, which I think technology is going to solve. Another barrier is when DR policies are not included in all diabetes and NCD policies. And we've heard from Stuart, I think there's been a lot of movement around having national guidelines approved in many countries recently. So there's work also to that. And finally, and I don't have an easy solution for that, but if you have a digitalized health system, registering, tracing, and contacting people with diabetes in order to screen them becomes much easier. In a lot of countries, there is no digital health information system, and therefore diabetologists or eye health and diabetes care need to work hand in hand even stronger to keep this seamless pathway for the people. Yeah.
Thank you. Thank you. One kind of almost final question to Chimsy. Why do you think people with diabetes in Nigeria experience such much stigma?
Okay, thank you so much. Yeah, I was actually gonna even answer a question because I read in the question section, somebody was asking why diabetes, living with diabetes, the assumption related to diabetes in Nigeria why it is regarded as why people living with diabetes in Nigeria are being stigmatized. Yeah, when I was diagnosed, few persons that got to know about it, that early stage of that diagnosis, which made me to live a private life, they kept on blaming me that I was living, that I was overeating, maybe I was having a poor lifestyle, I was not having a good exercise, and then shaming the individual. So these are some of the assumptions, and that has made me personally to, never to disclose these health challenges with anybody. And then some persons also think that living with diabetes is contagious. That's maybe when somebody living with diabetes comes around you, you will contact it, and then it has made social distancing and discriminations against the individuals. So there are so many assumptions, and one of the aspect of the relationship, the failed relationship, the parents of the young man thought that as a young girl living with diabetes, I was not going to be able to give birth to children for that family, and that was a major challenge for me. Even when the doctor told the young man that this is nothing, that she can give birth as many children as possible. So there are so many assumptions, and these are some of the discriminations, the stigma we face. So please, can I get the question you asked?
No, I think you just really answered to that question.
All right, thank you so much.
Thank you very much. So yeah, I mean, obviously extremely complex issue. So the final question now is to all speakers. Very quickly, please, if you had just one ask for governments to improve the way they prevent and manage DR, what would that be? I mean, just one sentence, please, because we're almost, I mean, a time when we have to finish. Anyone to start? Yes, Shannon?
I will go later.
Okay.
Universal coverage.
Universal coverage.
Yes.
Okay, good. Anyone? Another important point? Yes.
Diabetes education.
Education. Stuart?
I would say integrate of diabetic retinopathy in all diabetes policies.
Okay, so the policy level integration.
Policy level.
Yeah.
Okay, I would say more access to diabetes supply.
Okay, that's an important part of the universal access. Yes.
Okay.
Stuart?
And I reiterate Tova's key point about integration in the broader policies.
Okay, well, great, thank you. I think this is all very focused, and this is really what we need. And this is bringing us, I think, to the end of the session. And it's time for me now to thank all of you, and all of you, I mean the people who were part of the panel, but also all of you who participated. I think there was more than 1,000 people following this session, which is extremely encouraging. So thank you again. And just to remind you that the recording, the slides, and the feedback questionnaire will be sent to all registrants within a few days. Please respond to the feedback questionnaire, which is again important, particularly if you need to have a certificate of attendance. And you have here on the screen the email addresses where you can send the questions you may have. And then I think I have two important events to bring to your attention. First, the IAPB Vision 2030 Insight meeting that will be held in Mexico in June. Please please come and join. These meetings are very important for anyone who has an interest in eye health and prevention and blindness. And then we have a second very important event on the IDF side, which is the IDF meeting in Bangkok. And I mean, please keep in mind that the registration is opening on the 1st of April. And here again, please join this very important event. And on this, I would like to thank you again, all of you, from the bottom of my heart. And I wish you a lot of success in what you are doing in this extremely important area of public health. Thank you.